Hello and welcome everyone. Our today's topic of discussion is semen analysis. At the end of this session, the participants will be able to number 1 understand or explain the anatomy of male reproductive system. Number 2 enumerate the indications of semen analysis, and number 3 understand and explain the examination of semen. Now, what is semen? Broadly speaking, semen can be considered as a body fluid. There is no doubt about it. It is produced during ejaculation. It is a concentrated suspension of spermatozoa which is mixed with and diluted by fluid secretions from the accessory sex glands, namely prostate, seminal vesicles, and corpus gland. Okay. Now, 90% of the semen volume is formed by the secretions from seminal vesicle, which is to the tune of 50%, and secretions from prostate, which is to the tune of 40%. 5% of the semen volume is made up of spermatozoa, and the rest 5% is secretions from the accessory sex glands. Fine. Now, indications of semen analysis. Why do we need semen analysis? By far, the most important reason why we take up semen analysis is investigation of infertility. Okay. Now, most of the literatures, renowned literatures, they say that if a couple fails to conceive within 12 months or within 1 year of unprotected sexual intercourse, the couple is said to be suffering from infertility, and semen analysis is one of the first investigation which should be started with. Fine. Check the effectiveness of, number 2 is checking the effectiveness of vasectomy. Now, vasectomy is a surgical procedure where the vas deferens, which connects the testis to the urethra, is cut, and hence no spermatozoa can travel from the testis to the urethra. Is it that simple? There is more to it. It is said that a minimum of 15 ejaculations or a time frame of 12 weeks, which sums up to 3 months. This 15 ejaculations and or a time frame of 12 weeks should pass between two successive semen analysis, and these two successive semen analysis should show no sperm. Now, if we find no sperm in two successive semen analysis after 15 ejaculations, after a vasectomy, or after a duration of 12 weeks, we can easily say that our vasectomy is effective. Okay, this is how you check the effectiveness of vasectomy. Number 3. Okay. Number 3. Denial of paternity on grounds of sterility. Earlier, we saw that infertility was a condition where the couple was unable to conceive within 12 months of unprotected sensual intercourse. Okay. Also, infertility is also described as a reduced capability of an individual to produce offsprings, while sterility is a condition where the individual is not at all able to produce offsprings. Okay, so denial of paternity, this arises when a person is being accused that this guy or the man fathers children of some woman, but that guy can easily deny that I am not the parent of these children because I am sterile. So, denial of paternity on grounds of sterility. Number 4, medical legal cases. Most importantly, rape. Many times you need evidences to prove that yes, the rape had occurred. Many times the cases are false, many types they are true, but in cases of rape, semen analysis is done from the clothes of the accused and the victim. What next? Donor of artificial insemination. Okay, now most of us remember this movie Vicky Donor, a very nice movie, I must say, with a social message with it. So many times semen analysis is done for donation of what do you call spermatozoa in cases of artificial insemination. Now before we proceed further, I think it's very much important to have a look at the anatomy of the male reproductive system. Now this is the scrotum. This is the place where spermatozoa are formed. Okay, after production the spermatozoa are literally stored in a what do you call thick tubular structure which is called the epididymis. From here the spermatozoa arise in the vas deferens. This is the vas deferens. They enter the pelvic cavity and by the sides of the bladder. This is the bladder. Okay, they come to the posterior aspect of the bladder. At this point the vas deferens meets the duct from the seminal vesicle. Now as we remember, this seminal vesicle was responsible for 50% of the semen volume. Okay, so the duct from the ejaculatory duct and duct from the seminal vesicle, they meet and form the ejaculatory duct. Okay, they proceed further and they join the prostatic part of the urethra. This is the prostate. This pinkish thing is the prostate, and this tubular thing is the urethra. So and this is the prostatic part of the urethra. Fine. Prostate also pours its secretion into this what do you call tubular structure, and this is to the tune of 40%. Fine. So secretions from the prostate, secretions from the seminal vesicle, and secretions from the vas deferens, they all come together and form this volume of the semen, and ultimately they are ejaculated from the urethral opening. Fine. Now this is a sagittal section of testis. Why it is important, let's see to it. Spermatozoa, they are formed or produced in a tube-like structure which is highly coiled, and it is placed in various lobules in the testis. Okay, so these are seminiferous tubules in various lobules. Okay, these seminiferous tubules converge to form a net-like structure which is called the rete testis. Fine. From the rete testis, many ducts exit which are called the efferent ductule, and which ultimately meet and form a thick tubular structure which is called the epididymis. Okay, let's have another look. Okay, seminiferous tubule, the place where the production of spermatozoa was taking place. The seminiferous tubules converge to form a rete testis, a net-like structure. Okay, from rete testis many ducts arise. Sorry for that. Yeah, many ducts arise which are called the ductuli efferentes, and these ducts they converge to form the epididymis. One of the characteristic feature of epididymis is it traverses from the upper pole of the testis, comes down to the lower pole, takes a U-turn, and ultimately ends up forming the ductus deferens. Okay, as you can see, it's highly convoluted. Okay, and this acts as a site of storage of spermatozoa. Now this image, this is a low power view, a cross sectional view of the testis. You can see these pinkish circles, these are nothing but seminiferous tubule, and this whitish structure is the lumen of the seminiferous tubules. You can see many seminiferous tubules are lying close to each other. Also, you can see there are multiple dots in the wall of the seminiferous tubules. These are spermatogonium, which are the most primitive cells of spermatozoa, and you have got some Sertoli cells. Okay, now this picture here is a magnified view of this picture. You can see you have the wall of the seminiferous tubule. Okay, this is the lumen, and these bluish dots are spermatogonium, primary spermatocyte, secondary spermatocyte, and Sertoli cells. Okay, now this is a diagrammatic view of the seminiferous tubule. It will help you understand better. This bluish line is the base of the seminiferous tubule, and towards the base lies the spermatogonium. You can see these are the spermatogonium. These are the most primitive cell from which mature spermatozoas are formed. Okay, also interspread in between the spermatogonium are Sertoli cells. These are Sertoli cells. What is the role of the Sertoli cells? These Sertoli cells literally nurse the growing or the maturing spermatogonia. Okay, and ultimately when the spermatogonia mature to form the spermatozoa, they are released in the lumen. You can see many spermatozoa lying in the lumen of the lying in the lumen of seminiferous tubule. Now look at this diagram. The most primitive cell to start with was the spermatogonia. It undergoes various divisions, mitotic and meiotic divisions, to form primary spermatocytes, secondary spermatocytes, spermatids, and ultimately matures as a spermatozoa. The same picture, the same thing with a different kind of diagram. Okay, the most primitive cell is the spermatogonia, which has 2 times the number of chromosomes. It undergoes mitosis to form additional spermatogonia. Okay, also after mitotic division, it forms the primary spermatocyte. You can see the chromosome number is still maintained. This primary spermatocyte undergoes the first meiotic division, producing 2 daughter cells, and also you can see the chromosome number is halved. Okay, this primary spermatocytes undergo second meiotic division, forming the spermatids, retaining the number of chromosomes. Okay, and forming 4 spermatids from 2 secondary spermatocytes, and ultimately these spermatids mature further to form the spermatozoa. Now, before we proceed to for a semen analysis, it is very important to have a sample. So, but before asking the patient for the sample, there are few things we need to explain the patient regarding what is to be done and what is not to be done while collecting the sample. First, the sample should be produced at the laboratory. Now, what is the idea behind the statement? Number one is time. Time is very important whenever we intend to do a semen analysis. Okay, as soon as the sample is collected, I think literally the analysis starts, because from the time of collection to the time of liquefaction is somehow calculated. Okay, so it is very important to take the exact time of collection. So it is also important that if the sample is produced in a quiet room in the laboratory premises, I think the time lapse won't be much before too much delay is uh, too much delay takes place. Okay. Secondly, uh, temperature. Extremes of temperature, especially hot temperature, exposure to extremes of temperature is not at all what do you call extremes of extreme exposure to hot temperature is not at all required. Okay, that is not wanted in case of semen analysis. Many a times what happens that many patients are not comfortable in producing semen samples in the laboratory premises. So in those cases, those patients are provided with special condoms, okay, non-spermicidal condoms, and they are asked to produce the semen sample at their home. Now it is very important that you should explain the patient that, okay, after you have collected the sample at your home, you should bring the sample to the laboratory in the minimum possible time with a minimum temperature difference. Okay, with a minimum temperature difference, meaning that his house is almost 20 minutes apart, but while coming from his house to the laboratory, this person has exposed the semen sample to extreme of temperature, extreme of sun, extreme of the what do you call the weather elements. That is not advocated. Okay, so it's very desirable that the sample should be produced at the laboratory. Abstinence of 2 to 7 days. Now abstinence literally means staying away. Okay, abstinence from alcohol, abstinence from smoking. Okay, similarly, in case of semen analysis, abstinence literally means staying away from sexual activities. But I think more than the sexual activity, it should be staying away from any activities which results in loss of semen. Okay. Now the time duration said is a minimum of 7 days to a maximum of a minimum of 2 days to a maximum of 7 days. Now the explanation behind this 2 to 7 days is anything less than 2 days you will end up with a low semen volume. Okay, and anything more than 7 days, yes, you will have a high semen volume, but at a cost of low quality of semen or the low quality of spermatozoa. So the ideal time between of abstinence before a semen analysis is 2 to 7 days. Now it is very important that the sample pots, the containers in which the semen is collected, should be wide mouth. The idea is any semen loss is to be reported to the laboratory concerned. Okay, you should explain to the patient that the patient should try his best possible, take as much precaution as possible to collect the semen into the what do you call sample pot, and any what do you call spillage of the sample should be reported to the laboratory. Okay, this sample pot should be non-toxic. Non-toxic to what? Non-toxic to spermatozoa. Okay, sterile. Okay, if you need to perform some microbiological examination on the spermatozoa or the semen, a sterile pot is advocated, else a clean container will suffice. Hygiene. Until unless you are going for a microbiological test, washing the genitalia and the hands with soap and water is not at all required. Just for normal semen analysis, washing the genitalia and the hands with water is more than sufficient for a hygienic collection. Okay, and if for any reason a repeat analysis has to be performed, it should be performed between 7 days and 3 months. Okay, now as I said earlier, semen can be treated as any other body fluid, and most of the body fluids, they are tested in the laboratories under 4 or 5 headings. Okay, similarly the semen can be examined under these headings, namely physical examination, chemical examination, microscopic examination, microbiological examination, and immunological examination. Okay, now coming to physical examination first. Okay, number 1, appearance and color. Okay, now semen, most of the book say that semen looks somewhat grayish white and it is opalescent. Okay, this is the usual description what most of the books give for the appearance and color of the semen. Now what is important is deviation from this color and appearance. If you find that the semen is appearing somewhat reddish, suspect hemorrhage. Okay, hemorrhage, I hope I got the spelling wrong, but you get the idea what I am trying to write. Okay, if the semen is appearing reddish or pinkish, yes, it might also appear pinkish, suspect any hemorrhage into the urogenital system. Okay, now if the sample appears yellow, think of jaundice or at times contamination with urine. Fine. Number 2, odor. The typical odor of semen is fishy. Fine. Any deviation from this odor, such as ammonical odor, if you encounter such an odor, then you can suspect that this semen might be contaminated with urine. Volume. Now most of the references, they say that the semen volume, the range of semen volume is a minimum of 1.5 to a maximum of 5 ml. Fine. Now there are few explanations where you can encounter a low semen volume and a high semen volume. Okay, let's look to it. Now coming to this diagram again. Now as we saw in our earlier slides, that the spermatozoa was produced in the scrotum with, and the secretions from seminal vesicle along with the secretions from prostate and what do you call corpus gland, these all form the total volume of the semen. Now in any condition where you have a blockage or a structure or a stone in the duct which comes out of the seminal vesicle, you will have a low semen volume. Okay, it is as simple as that, this place where the arrowhead is pointing, if you have a stricture or a blockage here, you will literally have a 50% volume which will be missing from our semen, so we will have a low semen volume. Okay, secondly, in cases of any lesion of the bladder neck, this is the bladder neck. Okay, many a times what happens, there is a condition called retrograde ejaculation. Okay, in this condition, instead of the semen ejaculating from the urethral meatus, it runs back into the what you call bladder. Okay, this occurs due to some lesions of the bladder neck. In this case, again you will end up with low semen volume. Also, there is a condition which is called prostatitis. It is an inflammatory condition of prostate, and in these cases you usually end up with increased semen volume. Fine. So 1.5 to 5 ml is the normal range. There are reasons for low semen volume, retrograde ejaculation, or what do you call Any obstruction to the duct of the seminal vesicle may lead to low semen volume, and high semen volume may be because of prostatitis. Next, pH. Now again coming back to this picture, just a minute. Let us clear this thing out. Yeah. Now, pH. The pH of semen is around 7.2 to 8. That means it is more towards the alkaline side. Now, look, let us go back to this image again. Now, as we remember, seminal vesicle was contributing to, just a minute, let me change this color. Yeah, seminal vesicle was contributing 50% of the semen volume. Also, the secretions from seminal vesicle is on the alkaline side, while the secretion from the prostate is on the acidic side. Okay, so the ultimate or the resultant pH of the semen is a sum of, or a, what do you call, yeah, you can call it a sum of the end result of the acidic and the alkaline pH of secretions from the seminal vesicle and the prostate. Okay, so this comes to 7.2 to 8. This is the range of pH of semen. Okay, and how do you measure the pH? Usually you should be using a pH paper, and it is recommended that the pH paper should range from 6 to 10. Fine. Okay, let's erase this thing again. Coming back, viscosity. Now, viscosity is described as a resistant or a resistance to flow of fluids. Okay, it is the resistance to flow of fluids. Fine. Now, our semen is said to be a viscous solution, but as the time progresses, this semen liquefies by 20 to 30 minutes. Okay, now this liquefaction of the semen within 20 to 30 minutes is because of the proteolytic enzymes which comes from the prostate. Fine. Proteolytic enzymes will come from the prostate, and this is the is responsible for liquefaction of the semen. Next point, liquefaction time. As I told earlier, it is between 20 to 30 minutes. Now, what happens if a semen sample doesn't liquefy even at the end of 30 minutes? What you should do, you should again give that sample 30 minutes more. Okay, so 30 plus 30, that means 60 minutes is the upper limit what you should be waiting. And if at all the semen doesn't liquefy even at the end of 60 minutes, you should give a note in your report that the semen sample did not liquefy even at the end of 60 minutes. Okay, fine. Let us erase these things again. Now, next to physical examination is chemical examination. Now, for your B.Sc Nursing service, I think enumeration of chemical examination is more than enough if a question of semen analysis comes in your exam. Now, just remember we dealt with three glands. One was the seminal seminal vesicle. This seminal vesicle is responsible for secretion of a chemical which is called the fructose. Okay, and a positive test for fructose gives a red color. Fine. Similarly, apart from seminal vesicle, we had another organ which was the prostate. Okay, the chemicals which are secreted from the prostate are total zinc, total acid phosphate, and citric acid. Okay, and the third one, epididymis. The chemical which is a marker for epididymis is the alpha glucosidase carnitine. Fine. Now coming to the microscopic examination of semen. Under microscopic examination, we take a few things. Number one is sperm count. I think sperm count, the word count is not appropriate. I will explain to you in a moment. Sperm, but for the sake of understanding, let's take it. Number one, sperm count. Number two under microscopic examination is sperm motility, and number three is sperm morphology. Okay. Apart from that, apart from examining sperms, other cells are also examined under the microscope. We examine for bacteria, we examine for RBCs, WBCs, epithelial cells, and immature germ cells. Now, let us proceed further. Number one was under microscopy was sperm count. Right? Now, sperm is counted in a specialized thick glass slide which is called the improved Newber's chamber. Fine. Just a minute. Yeah, improved Newber's chamber. You have two specialized markings etched onto the glass of the Newber's chamber, which are placed here. Okay, and by the sides of these two markings are two channels. Okay, these channels are literally interconnected. Okay, these channels contain semen. Okay, and this semen is literally poured here using pipette, and the semen flows. If you put it at this point, the semen flows all throughout this channel, and it also floods these two counting chambers also. Fine. It's very difficult to make you understand without showing the actual Newber's chamber, but still let us hope. Okay, if you look at the the slide from its longer side, you can see that there is a plateau. Okay, on this plateau is etched the markings, ruled markings for counting of the cells, in our case spermatozoa. These are the channels I was talking about, and just towards the outside of the channels are two raised ridges. These are the two ridges. Okay, this is the ridges. These ridges have a height of 0.1 millimeter or 1/10 of a millimeter from the surface of the plateau. Okay, so any volume which is trapped inside this means this glass slide or the cover slip, and the glass plateau of this slide will have a depth of 1/10 millimeter. Okay, and depending upon with what area do you multiply, it gives the volume. Okay, area, whatever area you take, multiply it by 1/10 of the volume, and you get the volume, means area by 10 millimeter cube is the volume what you get for calculation of or counting of the cells. Now look at this picture. This is how a improved Nuber's counting chamber looks like. Okay, this whole length is 3 millimeter, of which this is 1 millimeter. From here to here it is 1 millimeter, and from here to here it is 1 millimeter. Similarly, from here to here it is 1 millimeter. Again, from here to here it is 1 millimeter, and from here to here it is 1 millimeter. So this total chamber has an area of 3 into 3 millimeter square. Fine. Now these squares 1, 2, 3 and 4 are used for counting fluids which have low cell count, such as the WBC. Okay, and this center chamber, which has got much denser marking, is used to count fluids which have got high cell count, such as RBCs, semen and also platelets. Now look at this image. This is a magnified view of the same center square. Now whenever we are calculating semen, or a semen, trying to ascertain a semen count, 5 smaller squares from the center square is taken, or rather are taken. Okay, you can see 1, 2, 3, 4 and 5. Okay, it depends on you whichever 5 medium sized squares you can take. Okay, in this picture we have 1, 2, 3, 4, 5. You can choose 1, 2, 3, 4 and 5. 1, 2, 3, 4, 5, or you can use 1, 2, 3, 4, 5. Okay, the choice is up to you, what whichever. Just a minute, sorry. Yeah, the choice is up to you, whichever medium sized squares you want to take. The thing is, you have to take 5 squares. Now the calculation of this thing is a bit tricky one, and I think until unless you look up into the books, it's a bit difficult to understand, but it's not that difficult. Okay, now semen, as we say, contains a large number of spermatozoa, to the tune of millions. So it is very important to charge this Nuber's chamber with a diluted semen sample. Okay, it depends whether the dilution is 1:20 times or 1:200 times. Right, ultimately whatever the calculation comes, you have to multiply that calculation with the dilution factor. Okay, these are dilution factor. Okay, so this is how we calculate semen, or rather sperm count. Okay, now I would like to emphasize on 2 things which are very important. Okay, I told sperm count. The term count is technically not good, I must say. The actual term is sperm concentration. Fine. How do you define this thing? It is the number, or n. Let's take that n is the number of spermatozoa. Number of spermatozoa divided by the volume of semen in which it was calculated, and the unit is per ml. Okay, so the lower range of sperm concentration which WHO has said is 15 into 10 to the power 6 million, or rather 10 to the power 6 means it's in million, sorry for this thing, 10 to the power 6 per ml. This is the lower reference range of sperm concentration. The another term which is very much used is the sperm, rather total sperm number. Okay, how do you get this thing? You just have to multiply the sperm concentration by the volume of ejaculate. Okay, so suppose a person ejaculated 4 ml of semen and his sperm concentration came to this thing, 15 into 10 to the power 6. So his total sperm number will be 15 into 4 is 60 into 10 to the power 6. Fine. So let us not concentrate on sperm count, but rather concentrate on sperm concentration and sperm number. But for understanding purposes, most of us teach this way. Okay, sperm count. Now coming back to the presentation again. Okay, sorry. This is how the spermatozoa looks like under a bulbous chamber. The red markings are the markings on the bulbous chamber, and the small cells which are moving randomly are the sperms. Now if you look closely, you can see that some of the spermatozoa are moving rapidly. Okay, rapidly, but some of them are still moving, but they don't have any progression. Look at this guy. Okay? It's moving, but it has no progression. This guy, it is moving, but it has no progression. But look at these guys. Okay? This one. Okay? This one. They're moving in a very random way, and they have a progression to their movement. Okay? And this is a slide which is seeded on a drop of semen on a normal glass slide covered with a cover slip. Okay? You can see various blackish dots moving. Those are spermatozoa. This is a somewhat low power view, I think. Fine. Now next in the microscopic examination, second to count is the sperm motility. Now as we saw in the previous two slides, there were some spermatozoa which were moving very rapidly, and there was certain progression in their movement. So such kind of motility is described as progressive motility. Okay, the spermatozoa move actively, either linearly or in a large circles, regardless of their speed. Okay, this is the first type of movement what the spermatozoa show. The second type of movement what the spermatozoa show is a non-progressive movement. Okay, they move in a single place, but there is literally no progression in their movement. All patterns of motility with an absence of progression, example swimming in small circles, the flagellar force hardly displacing the head, or only when a flagellar beat can be observed. This kind of motility is expressed as non-progressive motility. And the third type is the immotile forms. Yes, immotile means it's not at all moving. Now mind you one thing, immotility never means the spermatozoa is dead. Maybe it is running so short of energy that it cannot move itself. Okay, so in motility what we have, we have PR progressive motility, NPR non-progressive motility, and IM which is for immotile forms. Now the lower reference limit for motility, or rather total motility, which is progressive motility plus non-progressive motility, is 40%. Now it is very important that to conceive, the person should, or the semen of a person should have sperms which have at least 40% motility of total motility. Okay, and of this 40%, I must say the total percentage of progressively motile cells should be 32%. Fine. Now this is how, this is the third type under, this is the third point under what you call microscopic examination, which is the morphology. Yes, sorry, I failed to write. So this is under morphology. Now WHO has laid down a very strict criteria about how the spermatozoa should look, and any deviation from the normal looking spermatozoa, it says that consider those spermatozoas as abnormal. Okay, and in semen analysis, a ratio of normal to abnormal spermatozoa on what is the percentage of normal spermatozoa is usually mentioned in the report. Okay, so a normal looking spermatozoa has a round to oval looking head, has a short neck, a middle piece, and a slender tail. Okay, this is how a normal spermatozoa looks like. So this is a diagrammatic representation of how normal and abnormal spermatozoa look like. Okay, you have got big heads, small head, two heads, two tails, pointed head, somewhat crooked head, and a crooked neck or a midpiece. These are the abnormal variety or the abnormal morphology of spermatozoa. Again, the same thing. Okay, large head, pinhead, two head, abnormal head, tapered head, bent tail, and abnormal midpiece. Okay, now we will come to this picture in a moment. Now I'm skipping on to the microbiological examination of the what you call semen. Okay, but I think it will be dealt in your microbiology classes. Fine. Now moving further, the next test what we perform in semen analysis is the semen vitality. Vitality is a term which is used to ascertain, or rather to describe whether if someone or something is vital or living. Okay, now if we have, or if on microscopic examination we find that the progressive motility of the sperms is less than 40%, then this test comes to play. Okay, what are the tests which we undertake under sperm vitality test for your level? I think these enumeration of these three tests is just more than enough. One is hypoosmotic swelling test, number two dye exclusion test, and number three is the supravital stain. Sorry for that. Now just something about this test, hypoosmotic swelling test. Semen or spermatozoa are placed in a solution which have a osmolarity lesser than that of the what you call sperm. Okay, so they are placed in a, spermatozoas are placed in a hypoosmolar swelling. So what happens? Fluid by osmosis moves from the fluid, means the solution, to the into the spermatozoa, and these are the changes what you can expect. Okay, you can see number figure A show no change, but as depending upon how hypoosmolar the swelling is, these are the kind of changes we can see. Okay, and these changes are usually evident at the tail. The idea behind is living spermatozoa have an intact cell membrane, and these and this cell membrane acts as a semi-permeable membrane through which only solvent passes, and which ultimately causes swelling of the tail portion of the spermatozoa. So hypoosmotic swelling test tells how many sperms are living. All those spermatozoa which swell up are living in this test. Okay, fine. Next test is dye exclusion test. Okay, as the name suggests, the sperm excludes the dye. Okay, the spermatozoa are placed in a dye, but intact cell membrane of spermatozoa doesn't allow the dye to enter into it. Hence, the living spermatozoa excludes the dye, while the non-living one, what happens? The dead spermatozoa have their membrane ruptured, and into this that through this ruptured membrane, dye enters into it, into the spermatozoa. So under microscope, the living spermatozoa will appear unstained or very lightly stained, but dead spermatozoa, they appear as either red or pink. This is how dye exclusion test appears. Based on similar funda is your supravital stain using eosine. Okay, some immunological tests are also performed, okay, on spermatozoa. Few of the tests are to find the anti-sperm antibodies. Okay, and these are some special function tests performed on spermatozoa. Okay, at your level, I think just the enumeration of these tests is more than enough. Okay, so these tests go by the name zona binding test, acrosome reaction test, and the cervical mucus penetration test. Okay, this is a chart which shows the lower reference limits for the semen. We have got semen volume, total sperm number, sperm concentration, total motility, progressive motility, vitality, sperm morphology, pH, and a lot many other things. Okay, this another chart is for, I think this will help for your viva. This chart mentions the few nomenclature related to semen quality. Okay, just go through them once in your leisure time. So finally, take home message at the end of this session: gents first. Yes, infertility is a very big social problem in our society, but I think before you blame, or before anyone blames the female of the couple for not having children, I think the gents should take the initiative of getting himself examined. Okay, so gents first. Usually we say ladies first, but I think gents should come first. Okay, second, counsel and explain the patient regarding the prerequisites of sample collection. There are a few things which are to be told to the patient. What are the things to be done, what are the things not to be done before he comes for a semen analysis. Okay, even how to collect, where to collect, maintain the temperature variations if he is not collecting in the laboratory, and so on and so forth. Okay, and finally, um, finally, it's time is money. Okay, thank you for your patient listening. Thank you.